Hello, my name is Peter Sadow, and I'm going to be talking to you today about the evolving role for the pathologist in thyroid cancer diagnostics. Kinase fusion-related thyroid carcinomas is a prototype for this, but we'll also talking about the non-invasive follicular thyroid neoplasm with papillary-like nuclear features. I would like to thank the organizers for inviting me today to share this information with you. And I also want to share that I currently have no relevant financial disclosures, although I have worked previously as a consultant for Bayer Pharmaceuticals in relation to their NTRK inhibitors, and have also previously worked as a diagnostic consultant for Veracyte. So given that we don't have too much time to talk about things today, I'm going to focus my discussion on the role of the pathologist in surgical pathology and the state of pathology, particularly thyroid pathology, in regard to an update in diagnosis and the gross approach to thyroid neoplasias. Talk to you about some of the changes that have taken place for our field in terms of the molecular era of thyroid carcinoma and what the TCGA has really done for us in terms of expectations of pathologists and what we have to contribute to thyroid cancer diagnostics. And talk about the architecture, morphology, and genetics. How are we able to put those things together to say, can we look at the architecture? Can we look at the morphology in order to be able to give us an example of what we're expecting diagnostically? Look for molecular evaluations for the diagnosis, molecular evaluations for prognosis, and molecular evaluation to choose rational therapeutics. So the pathologist in surgical pathology, what is the dream of every surgical pathologist? Well, for anatomic pathologists, it's surgical pathology as a role for translational medicine. Our microscopic evaluations under what we see at the microscope, how does this translate into what is seen at the bedside? How does basic science translate into foundational biology informed by our clinical principles, driving the next generation of care? And or a pathologist who notices, oh, for instance, maybe I see a lot of inflammation associated with this tumor. What could this mean prognostically for the patient? And what does it mean in terms of choosing therapeutic options for this patient, having an inflammation-associated tumor? Aspiring pathologists are applicants. You know, we see applicants from residents that say, you know, they like to puzzle solve. They like to talk about the pinks and blues that they see underneath the slide coming alive before them. But really, what does it tell us about the fundamentals of human biology? For academic surgical pathologists, we look for people who share our desire to improve patient care by doing what it is that we enjoy most, which is advancing our practice. So I'm going to talk to you a little bit about the basics, the what of medical science, the diagnosis and the plan. So traditionally for us, it's an H&E, an ancillary test that tell you what the diagnosis is for the biopsy. But what if we actually talked about just doing ancillary tests only? So maybe pathologists become irrelevant and we can just do a blood test and look for molecular changes that are going to determine, hey, with these molecular changes, this particular patient is going to be treated with this particular drug. And we don't care if the patient has thyroid cancer, if the patient has liver cancer or colon cancer. All we care about is the following set of molecular changes. And how is it that we actually communicate with our clinical colleagues when a biopsy is non-diagnostic? Resections. What is the point of a resection, right? The primary point of the resection is to remove a particular cancer that's able to be removed. If we weren't able to completely excise the tumor, what is the next best possible scenario? So the resection is the relationship to the cure. Do we put in the appropriate sections in order to be able to make the diagnosis, make all of the comments about prognosis and any other relevant findings that may be helpful in terms of determining a care plan for the patient? Do negative surgical margins still have a role in the age of molecular medicine? So, you know, making sure that we get it all out. For sarcomas, making sure we get X number of centimeters around that sarcoma. Those are the types of questions that have become relevant now that we have such finely teased diagnostic markers. I put up a few historical photos from people that I've worked with previously, trying to understand how this works. So for instance, histologic and immunohistochemical decision-making for endometrial carcinoma. What are we going to do in terms of what are we looking for practically in order to make decisions about treatment of endometrial cancer? Cancer drug response and outcomes can predict cell mass changes. So we can see what happens when we actually take the tumor, make the diagnosis, understand the molecular findings, potentially do a liquid biopsy, treat the patient, and see tumor responses. So as a background in thyroid cancer, due to more intensified surveillance, thyroid cancer is being overdiagnosed. And I put that in quotes because what does it mean overdiagnosed? It means we find it more often, right? But overdiagnosed also is referring to the fact that we're not inappropriately diagnosing it or incorrectly diagnosing it, but we're seeing it more frequently because we find it more frequently. And what does that actually mean for patients, especially when what we call thyroid cancer may not actually be biologically aggressive disease that, if left alone, untouched in the patient, may never cause any type of clinical significant effect. So increased incidence is likely linked entirely to increased diagnosis of papillary thyroid carcinoma, which is the most common type of thyroid cancer and certainly the most common type of endocrine carcinoma. But if we think about this in terms of its relative importance to diagnostics in general, if we think about COVID-19, and I'm going to give you examples from the United States from the years 2020 to 2021, there were 49 million cases of COVID-19 diagnosed in the United States versus the neighborhood of about 50,000 thyroid cancer cases. And deaths from COVID-19 over that same period were 787,000. So quite a few number of deaths relative to the number of deaths of thyroid cancer. So we're really talking about very different disease types. And we're, as we focus on thyroid cancer today, sort of think about it as completely irrelevant when we have a worldwide pandemic going on. So as a background, in the early 2010s, we saw increases in diagnosis of papillary thyroid carcinomas, predominantly linked to increased diagnosis of the follicular variant of papillary thyroid carcinoma and increased diagnoses of papillary thyroid microcarcinomas. And particularly, when we talk about papillary thyroid microcarcinomas, we're talking about the really small ones that are incidental findings on patients that are having thyroid surgery for other reasons, either a larger nodule, Hashimoto thyroiditis, or even Graves' disease, and finding these incidental lesions versus lesions that were, somewhere in the neighborhood of 5 millimeters to a centimeter in size, which could legitimately be cancers that were noticed by ultrasound and possibly biopsied, even though recommendations from the American Thyroid Association are for biopsy nodules 1.0 centimeters or larger if it's a solitary nodule. Oftentimes, if patients come to their endocrinologist and receive an ultrasound and there's a nodule there, they end up getting biopsied even if they're smaller than 1 centimeter in size. The follicular variant of papillary thyroid carcinoma, we have typically referred to those in two different forms. One, the encapsulated follicular variant of papillary thyroid carcinoma, which is a well-circumscribed tumor, and the unencapsulated follicular variant of papillary thyroid carcinoma, which tends to be more infiltrative in its growth pattern. So this is the classic papillary thyroid carcinoma. Oftentimes they can be cystic, where we start seeing the nuclear features that everybody puts together with papillary thyroid carcinoma. So you have architectural pattern, which is the papillary fronds that grow that are leaf-like, and along with classical nuclear features of papillary thyroid carcinoma, which is the nuclear clearing, grooves, intranuclear pseudo-inclusions. Also talk about the presence of pseudomonas concentric ringed calcifications present that we see. And then when we think about follicular variant of papillary thyroid carcinoma that's well circumscribed, we can also talk about it being encapsulated. And when it's encapsulated, we can talk about whether or not it's actually invasive or non-invasive. And these tumors, when we look at them at higher power, they have some features of classic papillary thyroid carcinoma that you can see: nuclear membrane irregularities, some clearing, grooves, and very rare but occasional intranuclear pseudo-inclusions, pretty much absent Carcinoma bodies. We don't see fibrovascular cores because we don't actually see architectural papillae. So it's a little bit of a different animal. When we're dealing with the non-invasive follicular variant or encapsulated follicular variant, then the question is, in order to determine malignancy, is there capsular invasion? And people would get very caught up in thresholds, right? Thresholds for capsular invasion. So is this actually invading into the capsule? Is it invading through the capsule? What is my colleague going to call it? And people would be concerned. And I have to say, this is particularly pronounced in the United States, where people are concerned about a lawsuit. Am I going to get sued for this? And that ends up being the basis for deciding whether or not you're going to call something malignant is, what is someone else going to say if they see the same lesion? Now, this particular example, of course, there's no discussion about whether or not there's capsular invasion. We see true mushrooming invasion through the wall into the adjacent thyroid tissue, and this is not going to be up for debate or subjective diagnosis among colleagues. So traditionally for the non-invasive follicular variant of papillary thyroid carcinoma, the diagnosis had been based solely upon nuclear features to make the diagnosis, which is essentially also what cytology had been used for, was to make the diagnosis based upon nuclear features. There was no need for proving that there was capsular invasion. There was no need for proof of vascular invasion, and there was no need for evidence of architectural papillae that were needed to make the diagnosis of papillary thyroid carcinoma, despite the fact that papillae is part of the diagnosis, the term. So what are the cytological features? Nuclear clearing, nuclear membrane abnormalities, architectural papillae with fibrovascular cores, psammoma bodies, nuclear crowding, and sometimes a minor component of squamous metaplasia. So the cytological diagnosis of follicular variant of papillary thyroid carcinoma, typically without some of those architectural features, a lot of times the diagnosis would be atypia of undetermined significance or follicular neoplasm of undetermined significance, suspicious for follicular neoplasm, or suspicious for malignancy. Very rare in the case of a follicular variant papillary thyroid carcinoma would these lesions be called positive for malignancy because they were missing key features. Again, the key features that would be missing would be psammoma bodies, intranuclear pseudo-inclusions, and fibrovascular cores, which can still be seen cytologically. And of course, this would lead to an overdiagnosis of carcinoma. And again, this is not the equivalent of misdiagnosis, as I mentioned a little earlier, that these tumors subjectively or objectively could be called papillary thyroid carcinoma, but there's some doubt as to what the biological significance is of this diagnosis of papillary thyroid carcinoma. So more tumors being discovered due to increased screening, subjectivity in the diagnosis of follicular variant papillary thyroid carcinoma, which for pathologists, the concern is always, is somebody else going to call this cancer if I do not call it cancer? And so pathologists would be much more inclined to call this malignancy rather than calling it benign, taking the chance that if it would be sent, the patient would be sent to a different referral center, that someone would call it cancer, and that they would be told that they misdiagnosed something as benign when somebody else called it cancer. At least that's the feeling for many pathologists that were concerned to not make the diagnosis of papillary thyroid carcinoma. And this would historically lead to more surgeries for patients that maybe didn't require surgery because they're told they have cancer, or patients that had a hemithyroidectomy or a lobectomy, subsequently going for a completion thyroidectomy because they've been told they had or were subsequently diagnosed with cancer. And yet many of these cases never occurred just post-operatively. So if tumors don't recur post-operatively, were they really cancers? I say cancers because the diagnosis is correct to begin with. And cancer referring to not the pathology term of carcinoma, but cancer meaning a lesion that is going to behave aggressively, a lesion that is actually biologically at risk for causing death in the patient. So the non-invasive papillary thyroid carcinoma follicular variant, the treatment historically had been the same as for a classic papillary thyroid carcinoma, which was completion thyroidectomy plus radioactive iodine treatment. And the American Thyroid Association came up with new guidelines. Okay, this was in 2016, that had new recommendations for surveillance of these tumors. And these new guidelines, which came out about 6 years ago, for patients that had tumors that were greater than 1 centimeter and less than 4 centimeters in size, and these are patients that have thyroid carcinomas diagnosed as malignant, without evidence of extrathyroidal extension and without clinical evidence for lymph node metastases, again, because you'd actually need to take out the lymph nodes to prove pathologic metastases. The initial surgical procedure can either be a bilateral procedure, meaning a near total or total thyroidectomy, or a unilateral procedure. So if the patient was comfortable and the clinician was comfortable, the patient could have a thyroid lobectomy, even with papillary thyroid carcinoma, or even with follicular carcinoma, which would be sufficient initial treatment for a low-risk papillary or low-risk follicular thyroid carcinoma. And this, again, would mean the tumor is of reasonable size and no clinical evidence of lymph node disease. And what the definition is of extrathyroidal extension has actually changed even in the last couple of years, because we talk about extrathyroidal extension previously included microscopic extrathyroidal extension, which used to cause these patients to be diagnosed pathologically as a T stage of 3, even from microscopic extrathyroidal extension in a 2 millimeter microcarcinoma. But now, microscopic extrathyroidal extension is no longer considered in the staging of pathologic staging of thyroid carcinomas since 2017. And it's gross extrathyroidal extension, which is noted surgically by the surgeon to have tumor extending outside of the thyroid, or clinical evidence of adherence outside, or evidence of invasion into extrathyroidal strap muscles, for us to be able to call it extrathyroidal extension, which would be T3B. But during the time of these ATA guidelines, this is before the change in the qualification for extrathyroidal extension. So given the fact that these tumors often had very good outcomes clinically, a group of the Endocrine Pathology Society got together a working group in 2014, made up from 7 countries, 4 continents, 24 thyroid pathologists, 2 endocrinologists, 1 surgeon, 1 psychiatrist. Again, perhaps that was not actually even enough psychiatrists to participate. 1 thyroid cancer patient, 1 biostatistician, and 1 molecular pathologist. This group ended up examining 109 cases of patients with non-invasive disease, meeting all criteria of the group, with 10 to 26 years of follow-up following excision, and all patients were alive with no evidence of disease. And the conclusion from this study was that there needs to be a revision in the nomenclature of what we call encapsulated follicular variant of papillary thyroid carcinoma, given the fact that with at least 10 years of follow-up, these patients never recurred with disease. The main morphological features of the disease is it was follicular growth and pattern, and the nuclear features of papillary thyroid carcinoma. Again, that goes in quotes, the nuclear features, because that's a very subjective thing. No evidence of invasion, distinguishing it from invasive encapsulated follicular variant of papillary thyroid carcinoma, which I'll also mention what that may indicate. And these tumors have clonal origin with a driver mutation, indicating that the lesion, of course, is indeed neoplastic. Very, very low risk of adverse outcome. And of course, the idea of having very low risk versus no risk of adverse outcome is what needs to be actually put in place when you're making a prospective diagnosis, because you can't really talk about an entity having no risk until the patient's actually dead and has never had any adverse outcome. So very low risk, meaning that until you set up criteria for a diagnosis and then follow it over time, you can't actually prove there's no risk until you have appropriate follow-up from the advent of a diagnosis. So participants in these studies from the Endocrine Pathology Society had agreed set upon criteria for nuclear features, and this score ranged from 0 to 9, degree of nuclear features of papillary thyroid carcinoma. And if you allow yourself to sort of gaze upon the features, meaning score of 0 means 0 features of papillary thyroid carcinoma, where the nuclei are well-rounded, they are normochromatic, dark blue, without any indication of irregularities, no grooves, no pseudo-inclusions, no clearing, all of that stuff through the most well-formed nuclei, which is score of 9. And if you actually, just on this page from 5 to 9, and allow your eyes to toggle back and forth between 5 and 6, 7 and 8, 9 and 5, you'll see that it's really almost impossible to make this judgment. So if you every time you're looking at a case of papillary thyroid carcinoma, you're not looking at it in relationship to this made-up scale of degrees of well-developed nuclear features to be able to say, is mine a 5, a 6, a 3, or a 1? It's really quite impossible to put them in these particular categories, even though these were set up, based on some people getting together and saying, okay, these are the numbers. And so what that does set up for is this new wastebasket diagnosis, and the nuclear scoring system was set up for consistency. But the point being is that, for nuclear features, you either have them or you don't have them. So essentially, if you are, in this particular case, if you look at score 0 and score 1, it's really almost impossible to tell the difference. But the situation is, are there some nuclear features present or not? Yes or no, 0 or 1. And that would allow you to sort of put it in this area. So nuclear scoring system was set up for consistency, and the results concluded that a range of nuclear scores would deem a lesion benign or NIFTP versus minimally invasive encapsulated follicular variant of papillary thyroid carcinoma. And you can think about it that NIFTP is a follicular adenoma with nuclear irregularities. So it's not validated broadly, so that currently still designated as low biological potential versus no biological potential, but very, very few outcome studies have been published. So NIFTP requires no additional surgery. The original idea was that this would drive more lobectomies, but this is actually unclear now that the American Thyroid Association has changed its guidelines to include more of an active surveillance picture with low-risk cancers that are well-differentiated thyroid carcinomas. And the new Bethesda system was released in October of 2017, now 5 years ago. They're working on the most recent, the next edition that's coming out that had no changes. So what does it actually mean with no changes for the Bethesda criteria, including NIFTP? It means that the risk of malignancy now, the percentage of malignancy, would now be left shifted, whereas less tumors would be considered to be malignant when you start making fewer diagnoses of encapsulated follicular variant, although the classifications of atypia would remain the same. But fewer of them would actually be in the positive for malignancy once they actually come out. So because of the fact that NIFTP exists, the risk of people saying something is suspicious or positive for malignancy would move more towards the left, and you'd start seeing more tumors being put in the atypical categories or suspicious for follicular neoplasm category. But the submission guidelines or the criteria would stay the same. Then we talk about the original tissue submission guidelines, which are similar for solitary nodules. An invasion would remove from the NIFTP category, and it becomes invasive encapsulated follicular variant of papillary thyroid carcinoma. And the classification, of course, of these tumors is molecular driven. So encapsulated follicular variant of papillary thyroid carcinoma have RAS-like mutations, which means that when these tumors are behaving poorly, they don't metastasize to lymph nodes, but metastasize broadly to lung, bone, brain. And the infiltrative follicular variant of papillary thyroid carcinoma, those that you don't see well-circumscribed lesion, but you actually see broad infiltration without a capsule into the surrounding thyroid, those actually tend to be more likely to have BRAF V600E mutations. And we're going to talk about this again when we start talking about some of the fusions. And this was all derived from the Cancer Genome Atlas, which showed tumors to have, which was published in Cell in 2014, and showed tumors, papillary thyroid carcinomas, to really have two patterns of behavior: those that were RAS-like and those that were BRAF-like. So NIFTP and the encapsulated follicular variant of papillary thyroid carcinoma is the malignant evolution of NIFTP, which really is akin to the minimally or widely invasive follicular thyroid carcinoma, but this includes papillary-like nuclear features. So we start thinking about follicular adenomas, and when they become malignant, become follicular thyroid carcinomas, which can either be minimally invasive or widely invasive. And NIFTP is basically a follicular adenoma with nuclear membrane irregularities that can then become the invasive follicular variant of papillary thyroid carcinoma by invading through the capsule or invading into blood vessels. And it is very reductionist, but these are also thought to have RAS-like mutations, same as follicular carcinomas, but again, have variable nuclear membrane abnormalities. NIFTP does not require a capsule, so it just is a lesion that's well circumscribed. It has papillary-like nuclear features, and how does one assess the capsule if there is no capsule? And so we sort of replace capsule with tumor to normal parenchymal interface. And how do you actually adequately sample this? Well, the same way you would sample the capsule if you're assessing a solitary lesion for capsular invasion in the adenoma versus follicular thyroid carcinoma. And of course, it's advised that the entire capsule be submitted. And we start talking about architecture and papillae being present that actually can exclude NIFTP. And how do you look at the papillae if you're not looking at the entirety of the lesion? And that's somewhat of an issue. But when we're talking about tumor capsule, although the current trend is for the entire capsule to be submitted without respect to tumor size, this is really subject to your practices wherever you work. Like, for instance, European colleagues actually are much more cost effective than the US colleagues, where we submit the entire thing regardless in the US. And Europeans like that, we're not doing that. It's ridiculous, especially if it's a 10-centimeter mass. We're going to do representative sections. And we actually at Mass General Hospital published a study where we looked at this retrospective study from 25 years, looking at the submission practices, which evolved from doing representative capsular submission to doing the entirety of the capsule submission, where this change took place in 2010, where we went to full capsule submission. Prior to that was representative capsule submission. And really what we saw was there was literally no difference. The tumors that actually potentially had metastatic potential, and this is follicular thyroid carcinomas, were those tumors that were widely invasive. And the majority of widely invasive carcinomas did not go on to metastasize either. But if tumors went on to metastasize, those that did go on to metastasize were the ones that were widely invasive. And that the risk of metastasis from a minimally invasive follicular carcinoma was essentially the same as the risk of metastasis from an adenoma that was submitted with the entire capsule alone. So there was no difference between minimally invasive follicular adenomas, minimally invasive follicular carcinomas from adenoma. So that even though pathologists, we get very, very caught up on minimal invasion, and is this invasive versus not invasive, it doesn't really seem to matter unless the tumor is widely invasive. And oftentimes these widely invasive tumors, we know that when we actually see the growths. We don't need to look at it under the microscope to know it's widely invasive. So one other comment that I was alluding to just a couple of minutes ago is that one of the exclusion criteria for NIFTP is also no architectural papillae, that if they're present, this would be considered to be classical papillary thyroid carcinoma with predominantly follicular architecture. So this simple tumor to parenchymal capsuling would not be adequate because you wouldn't be looking at the entire tumor parenchyma to exclude the presence of papillae. And this is essentially ridiculous, especially why would we be looking at these tumors any more in depth, especially if it's a large tumor, than we would be looking at an adenoma capsule. It's just not really possible or feasible. So within NIFTP, if the entire tumor is not submitted, how do we ensure ourselves that we're not missing classic papillary thyroid carcinomas with predominantly follicular architecture? And we've been using BRAF-VE as a surrogate for looking at this thing. So now BRAF-VE is a monoclonal antibody, which is concordant with the BRAF V600E mutation. BRAF V600E mutation in thyroid is synonymous with papillary thyroid carcinoma. There is no such thing as BRAF V600E mutation in the thyroid that's not papillary thyroid carcinoma. And so sub-centimeter microcarcinomas, they may have BRAF V600E again, but even if they don't do anything, but if well assessed BRAF negative, HBME1 positive tumors would be considered to be enough to be NIFTP. So for instance, looking at HBME1, which essentially HBME1 is positive in tumors that have nuclear membrane anomalies, again, whether it's benign or malignant, but used to be a marker for papillary thyroid carcinoma. Now it's a marker for nuclear membrane irregularities, and BRAF V600E stain, BRAF VE stain, is a very, very helpful adjuvant to say whether or not this tumor with a predominantly follicular pattern is actually papillary thyroid carcinoma. So it's a very, very good surrogate marker for papillary thyroid carcinoma. So NIFTP debuted just about, about this point in time, 6 years ago, with several manuscripts in print since its debut, 340, as of earlier this year. Instructor reviews for pathologists have been published. The incidence of papillary thyroid carcinoma should decrease with the advent of NIFTP, but we talk about whether or not there's implications for surgery or the diagnosis of papillary thyroid carcinoma, but with the guidelines from the American Thyroid Association essentially saying that you can undergo active surveillance for low-risk papillary thyroid carcinomas, it's unclear whether or not the diagnosis of NIFTP actually will reduce surgeries just as well as doing active surveillance in well-differentiated thyroid carcinomas. So some implications: the reduced diagnosis of follicular variant of papillary thyroid carcinoma, possibly reduced overtreatment of indolent thyroid tumors, and also, importantly for our field, reduced need for consultation due to increased reproducibility of morphological features. So you don't have to have your personal threshold for nuclear membrane irregularities, that if you're nervous about a lesion, but it's well circumscribed, non-invasive, then you'd be able to use the diagnosis of NIFTP without worrying about whether or not the lesion is papillary thyroid carcinoma. And again, the Bethesda criteria haven't been changed. So atypia of undetermined significance, atypia of undetermined significance, or follicular lesion of undetermined significance would drive molecular testing. This is preoperatively and would be able to give you this RAS-like or BRAF-like mutation to be able to decide what you're going to do in terms of treatment of these patients. So how do we incorporate molecular features into the diagnosis? Are there molecular histopathologic correlates? And when do we do postoperative molecular testing, and does it matter? And this is the meat of the discussion that I wanted to bring to you as we finish up, is that we've started talking about papillary thyroid carcinomas with high-grade features, poorly differentiated thyroid carcinoma, anaplastic thyroid cancers. Where do we draw these lines? What is the mutational profile on these tumors? And the reason why we care is because for two reasons. One, we want to talk about prognosis for patients, right? That's typically what we've been able to do as pathologists. But now we're actually able to incorporate more than just prognosis. Oh, this tumor is really bad. We actually can recommend effective therapeutic options for patients based on their mutational profiles. So we're in the era of a dawn of actionable mutations. Our group, we published a study looking at clinical, pathologic, and molecular characterization of NTRK rearranged thyroid carcinoma, where we're actually able to look at the morphology of these tumors. And if you can see this nodular growth pattern of these thyroid tumors that are sort of somewhat indiscrete. And if you look at the top right of the screen, you'll see that this has this glomeruloid pattern of growth. The top left shows this micropapillary pattern of growth, and then you can see this more solid nodular pattern of growth, and again, a little bit more of that glomeruloid pattern of growth in the bottom right. And when you see that pattern of growth, you can say to yourself, maybe this tumor actually has a translocation associated with it, in this particular case, NTRK1. And here's another NTRK3, where you can also see this kind of nodular pattern of growth, looks more solid in its growth pattern, but kind of odd. The nuclei, if you look at them more closely, they don't really have standard papillary thyroid carcinoma-like nuclei. They are somewhat irregular. Maybe they're a little bit racinoid or somewhat, oddly angled in their pattern, but they don't have classic intranuclear pseudo-inclusions. The pattern's a little bit funny. They have it. So this is what these tumors look like, and then you can actually make it more broad to expand beyond NTRK and start looking at other fusions. Now, CCDC6 RET fusion previously was known as RET PTC. This is seen in diffuse sclerosing variant of papillary thyroid carcinoma. You remember that has those prominent microsomomatous calcifications that are peppered along the entire thyroid, often associated with Hashimoto thyroiditis, often associated with squamous metaplasia within the thyroid, may be associated with prior exposure to radiation therapy, often seen in young women. So we see these lesions there, and we can predict that they have these mutations, and these mutations respond beautifully to drugs. And so we actually are able to predict, based on the morphology, that these patients are going to respond to therapeutics. And they actually have a very minimal side effect profile, which may be some diarrhea. So we've been able to develop algorithms for testing in these lesions that can say, okay, if we see this growth pattern, the next thing we're going to do is we're going to do an immunohistochemical marker for BRAF mutation. And if it's negative for BRAF mutation, because we don't find these fusions associated with BRAF mutation, so if it's negative for BRAF mutation, then we can go ahead with whatever modalities that we have available to us to test them for fusions, particularly in NTRK or RET, but also in ALK, which is also druggable. Patients that, especially in patients, what setting, we have to talk about what setting these might be in. And these are patients that have advanced thyroid cancer, so they're not surgically resectable. They may be presenting with bilateral disease, or they have lung mets at the time of diagnosis. They have liver metastases at the time of diagnosis, and these patients respond beautifully to drugs, despite the fact that they may have advanced disease. So we're able to come up with our own way of being able to do it. And there's a number of papers showing how these targeted therapeutics are extremely helpful. And these same mutations, which can be seen in other disease sites in the head and neck, for instance, where we see them in salivary tumors, in other types of molecular targets, for instance, inflammatory changes that may be seen in head and neck tumors that are responsible to therapeutics, inflammatory therapeutics. We're seeing this really, really helpful findings of these translocations that are able to be treated, or doing immunotherapy for patients that have these diseases. So we have really changed how we're viewing these tumors in terms of how we're able to treat them. How are we going to look at these things going forward? COVID's changed a lot about our practice. For our department, what we've been able to do is, given the fact that at the beginning of COVID, we weren't even able to meet in person, we ended up having virtual tumor boards where we would meet with our own consensus group with MGH, and then actually expanded it to all of our alumni who are spread all over the US, showing difficult cases. And we're able to look at these cases and talk about our practice and how we're able to do it. And it's led to very broad collaborations about how we're able to look at these cases, which has unlocked new methods for diagnosis. What are you doing at your institution? How are you practicing? What modalities are able to be available to you? And by working together in consensus, we're able to say, what are best practices? How are your clinicians taking this information from you and applying it to their practice? And I think this has been really, really helpful for us, and things that we need to think about as practicing pathologists. So what is the role for the pathologist in surgical pathology, which is far greater than just making a diagnosis? What is the role of the pathologist in directing the science of tumor biology? And how are we going to evaluate follicular pattern thyroid cancers, which is evolving with molecular genetics and known clinical behaviors in these tumors? So NIFTP is new and continues to evolve. The role of genetics in accounting for the gross exam, how are we going to do it based on what we know about molecular diagnostics? The role in thyroid cancer, salivary tumors, and immunomodulatory therapies. And as we've moved forward in a molecular era closer toward integrated diagnostics, we must have more rational diagnostics. We have to integrate prognostic information, clinical next steps for therapeutics, and move our pathology consultative practice to the next level. So I thank you so much for your attention, and I hope you're enjoying these lectures.